Here's another interaction between the doctor and the patient with HIV and AIDS. This comes from a project that I was engaged in Sydney with Alison Moore and Gunter Plum, looking at HIV/AIDS interactions with patients across a range of different backgrounds, ethnic and linguistic backgrounds in Sydney. And the doctor says, I'll give you this one here, Indinavir. It's really easy to take. You take it before you eat. You reckon that's easy? Right. Look at that. Avoid food 1 hour before, 2 hours after taking it. Basically, if you were trying to do that, you'd never eat. I take it in the morning and then 2 hours later I'd be able to have my breakfast? That's right. It'd never work. Couldn't do it. Doctor says, couldn't do it. All right, okay. Now this is a very unusual kind of interaction in what one comes to see as the standard canonical relationship between doctors and patients. What we've got here is the patient, instead of taking a typical, the patient-doctor relationship, instead of being typically unilateral, if you like, and transmissive, is here a genuine kind of working together bilaterally in what one might call a kind of creative therapeutic alliance, where the doctor and the patient has to co-construct solutions to the patient's problems. And so what is happening is that there's a creative development, if you like, and utilization of various resources that they both have and which they're both familiar with from everyday talk. Now we could spend a good deal of time answering the question, why do they talk in this particular way? One of the reasons they talk in this particular way is that the treatment of HIV and patients with HIV and AIDS has to incorporate the patient because of the lifestyle effects of the treatment of retroviral drugs and so on, which are very complicated as regimes, and they can't simply be told. They have to be negotiated, and of course, the kinds of patients we were talking with had access to rather a considerable amount of information about their own condition, which they were able to bring into the interaction. So you get a different kind of interaction, which I think is creatively different from that you would find in a more traditional kind of unilateral relationship. Let's take this last two examples, and I'll use some of these in a minute when I look at the whole text. Here again, this comes from this oncology consultation project, in which we're looking at the interaction between oncologists and patients with varying degrees of cancer about the treatments that they might effectively undergo. The first one, and it's not uncommon for women to sit where you're sitting and say, I'm prepared to take a 50% chance, I desperately want to keep my breath. What I'm going to do is look at that in a minute, the way in which the doctor voices, as it were, the perceived views of a patient as a way of introducing that kind of information into the consultation. Again, the doctor says a little late in another consultation, you might say to me, look, I can't live with uncertainty. I want to be done with it. And on the other hand, you might say, look, I do anything to avoid having chemotherapy. And so here again, you've got a very interesting relationship where the doctor creatively takes on, if you like, the voice of the patient in order indirectly to present possible alternative actions, but not in the form of either direct statements or questions. And then finally, in these brief examples, we have a doctor talking to, again, a patient, a female doctor in this case talking to a female patient, and this is from our Royal Australian College of General Practitioners project. So the ovarian cancer, your level of worry about it should ease. Okay, now let's just have a look at patient. I'm not really worried about it, doctor. No, but it's something as women, yes. Very interesting here how the doctor brings to the fore the notion of gender similarity. Of course, they're both women, as a way of indicating to the patient a kind of, not only a kind of rapport, but an empathy with her particular condition. So what is happening here is that the doctor creatively is associating herself more directly with the patient. Okay, so we can ask ourselves, what is the nature of such strategic resources in professional discourse? We can ask, what is their source? How are they drawn upon creatively, individually, or co-constructed in critical moments in given crucial sites? What is their relationship to work and action? How pervasive are they across discourse types and activity types? How are they realized semiotically? How are they recognized as significant and by whom? And what role do they play in defining professional expertise? And these, I think, are some of the discourse analytical questions that we might want to ask ourselves in relation to the kind of discourse data I'm interested in and from a creative point of view. Now, coming back to the notion of the relationship between activity type, professional practice, and discursive practice, this particular slide tries to lay it out, if you like, in the medical context. The medical consultation is seen as an activity type relating to a professional practice which involves a number of discourse types, history taking, troubles talk, counseling. A discursive practice involving strategies such as talking plainly, giving face and deference, thinking aloud, etc. And a semiotic practice involving all of these sayings, writings, and doings as realized behavior. The point I want to make here is that from an analytical point of view, we have creatively to move between these different constructs, looking at the different kinds of discourse types that are involved, how they interplayed with each other within an interaction, and how they come to define for different kinds of groupings what they understand by the notion of a medical consultation. And then, of course, looking at discursive practices as a bank of strategic resources that doctors can, as it were, creatively select from at particular moments in the interaction. Now, in the example I want to look at, and I'm probably going to run over about 5 minutes, if that's all right with you, I want to look at this notion of voicing and interdiscursivity as a creative strategy, as an example. And as a background, in this extended consultation, we're defining voicing as the construction of a dialogue in which the oncologist introduces an alternative perspective by projecting into the interaction the direct speech of another person who's usually the patient. Now let's have a look at this particular interaction which you've got on your handout. The patient is a middle-aged woman with an early stage diagnosis of breast cancer. She's had an excision of a cancerous lump and breast conserving surgery. And the issue is that in the early breast cancer stage, the choice is between two equally effective options, either a lumpectomy followed by radiotherapy or a total mastectomy. And the issue is that of the patient wishing to keep her breast, as it were, within that particular context, or whether the patient wishes to keep her breast within that context. It's clear, and from our discussions afterwards, the doctor believes that mastectomy will offer the best chance of cure. The issue is that the doctor, however, doesn't know at this first consultation the extent of the patient's desire to retain her breast. So what you have in these lines from 117 to 128 is essentially risk talk, which culminates in line 127. It's about 50%, it's about 1 in 2.